Morning, y'all. Millions of kids get ADHD pills before they ever meet a therapist. Numbers from National Health data sets show more than 4 in 10 preschoolers receive medication from within a month of diagnosis. Clinical guidelines say the first step at that age should be parent-focused behavioral work. Only about a third of newly medicated children had that support in place. Families often move fast because schools push for quick change. Pediatric offices do the same, and specialty care wait lists stretch for months. So stimulants become the first tool pulled from the shelf. Once started, the path widens. Children who begin stimulants are many times more likely to end up on second or third psychiatric medications within a few years. Large administrative studies have tracked this pattern for years. Roughly 1 in 4 kids on stimulants receives another psychotropic drug. The combinations differ in strength and evidence. Using a stimulant with an alpha agonist is the best supported pairing of targets, residual symptoms, or tics. Adding antidepressants has mixed results. Adding antipsychotics carries higher risk, weight gain, sedation, metabolic shifts, and lacks strong support for improved ADHD symptoms themselves. Age shapes outcomes. Younger children who start medication early are most likely to move into multi-drug care later. Their brains are still developing and their symptoms more variable, which leads clinicians to try prescriptions when behavior swings. Another force sits in the background. Trauma shows up in inattention, restlessness, irritability, and impulsive behavior. Studies on youth and adversity show these trauma-based symptoms are often masked by ADHD. When trauma goes unrecognized, medication becomes a response instead of therapy aimed at the underlying stress. Not all findings point in one direction. Long-term registry research shows stimulant treatment alone can reduce hospitalization, lower crisis episodes, and improve emotional control for many kids. Stimulants remain one of the most studied and effective treatments in pediatric mental health. What we don't have is the same depth of evidence for long-term use of 2, 3, or 4 medications in young children. Across the data, single picture forms. Early diagnosis leads to early prescriptions. Behavioral care is hard to reach. Trauma gets overlooked, and multi-drug paths grow out of these starting points. Both of it.